Okay. So good evening all. Today we are going to discuss the perioperative management of tricuspid atresia. Tricuspid atresia is not very uncommon congenital cyanotic heart disease. Before discussion about the anesthetic management of the tricuspid atresia, we need to know in detail about the pathophysiology, the classification, and the initial management about the tricuspid atresia. Until and unless we are having a clear idea about the classification, different types of tricuspid atresia, and the pathophysiology of those specific types, we cannot manage a child with tricuspid atresia in the operation theatre. So let's start about the discussion on tricuspid atresia. Tricuspid atresia is defined as complete obstruction of the atrioventricular valve of the morphologic right ventricle, and it's a type of single ventricle lesion. So, as there is no direct communication between the right atrium and the right ventricle, so right ventricle is getting lesser amount of blood, so typically it remains hypoplastic. One more very interesting characteristic finding of tricuspid atresia is that although it is a cyanotic heart disease, but there is commonly associated left ventricular hypertrophy. So a lesion which is having LVH and cyanosis at birth, more or less the diagnosis is tricuspid atresia. Coming to the embryology, a little known about the detailed embryological background of development of tricuspid atresia, but it has been postulated that the tricuspid atresia is occurred as a result of malalignment of the ventricular septum in relation to the atria and the atrioventricular canal. Normally there is formation of RV sinus, which is ultimately developed into right ventricle. The absence of right ventricular sinus during development results in a shift to the right of the ventricular septum and ultimately obliteration of the right atrioventricular orifice. The ultimate size of the right ventricle also is determined by the extent to which the septum is shifted to the right and the size of the associated ventricular septal defect. So malalignment of the ventricular septum with the atria as well as with the atrioventricular canal, along with that the absence of RV sinus ultimately results in right shift of the ventricular septum and obliteration of the right atrioventricular orifice, leading to development of tricuspid atresia. Now coming to the classification, which is very important. The classification is a little difficult to understand. It is of three types: type 1, type 2, and type 3. Type 1, and this classification is actually based broadly on the orientation of the great arteries. In type 1, there is no abnormal orientation, so there will be normal great arteries. In type 2, there will be DTGA, and in type 3, there will be LTGA. Now, type 1 is having three subtypes. Type 1A is that normal great arteries with tricuspid atresia with pulmonary atresia. Type 1B is normal great arteries with tricuspid atresia with associated restrictive VSD and pulmonary stenosis. In type C, there is non-restrictive VSD and no pulmonary stenosis along with tricuspid atresia and normal great arteries. So in type 1A to C, there is change of pulmonary blood flow normally. In type 2, which is DTGA, again it is subclassified into three types. Type 2A, before that, in all the three subtypes of type 2, there is presence of VSD. In type 1A, there could be absence of VSD, such as in type 1A. But in all types of type 2, there is presence of VSD. Type 2A, there is pulmonary atresia. Type 2B, there is pulmonary stenosis. And type 2C, there is no pulmonary stenosis. But in all these varieties, there is always presence of ventricular septal defect. Type 3 is LTGA. So this is the classification of tricuspid atresia. Now, coming to this picture, that it is the type 1A, that is tricuspid atresia with no VSD and with pulmonary atresia. You can see a very thin pulmonary outlet. Type 1B, there is presence of very small restrictive VSD. Along with that, there will be pulmonary stenosis or pulmonary hypoplasia. In type 3, there is large VSD, non-restrictive VSD, and there is no pulmonary stenosis, no pulmonary atresia. So this is type C. Coming to the type 2, that is DTGA. See, in type 2A, 2B, and 2C, in all these subvarieties, there is presence of ventricular septal defect. Type 2A is having pulmonary atresia. Type 2B, there is pulmonary stenosis. And type 2C, there is no restriction of pulmonary blood flow. That is, there is no pulmonary atresia or stenosis. Type 3, that is LTGA. Again, it can be subclassified into two types, 3A and 3B. 3A, there is presence of pulmonary or subpulmonary stenosis, and type 3B, there is presence of subaortic stenosis. And definitely, VSD is present in both the two types of subtypes. So, anatomy of different types of tricuspid atresia in detail. There could be three subtypes of pulmonary atresia, but all forms share four common characteristic features. Number one, there is lack of communication between the right atrium and the right ventricle. Number two, there is presence of an interatrial communication. Number three, there is an enlarged mitral valve. And number four, a hypoplastic right ventricle, usually in communication with the left ventricle via a VSD. So, what about the anatomical details of tricuspid valve? In tricuspid atresia, we can see different types of anatomical varieties in the location of tricuspid valve. The most common is muscular atresia, in which no tricuspid valvular tissue is found, but a dimpling in the muscular floor of the anatomic RA is present. This dimple is presumed to be the location of atretic tricuspid valve. Then comes the membranous form. In membranous form, the membranous portion of the atrioventricular septum between the RA and the LV forms part of the floor of RA in the expected location of the tricuspid valve. Then a valvular form, which is identified by a thin imperforate membrane consisting of minute fused valve leaflets. Then a rare Epstein form, where valvular tissue is found with fusion and Epstein deformity of the tricuspid valve leaflet. And lastly, a very rare form with complete avicanal defect. Here the orifice of the RV is sealed by the RV aspect of the common atrioventricular valve. So these are the types of tricuspid valve in tricuspid atresia: muscular form, membranous form, valvular form, Epstein form, and rarely avicanal form. What about the interatrial communication? A true atrial septal defect is present almost in 1/3 of the patient, and it is usually of ostium secundum type. But an interatrial communication could be restrictive also. This interictal communication is important for the surviving of the baby in type 1A and type 2A type of tricuspid atresia. In some patients, there could be a patent foramen ovale present, which is almost in 2/3 of the patient. The foramen may be widely patent or restricted. There could be associated aneurysmal dilatation of the foramen ovale or the right atrium, which may cause obstruction of blood flow from the right to the left side. Less commonly, a primum type of ASD or even very rarely, complete absence of atrial septum may occur. And as you know, the survival in presence of complete absence of any ASD or any PFO is difficult for the child. What about the mitral valve? As I've already mentioned, that it could be large, as because both systemic and pulmonary venous region pass through the morphologic mitral valve into the left ventricle. Normally, it is having 2 leaflets and an enlarged orifice, but sometimes that because of this excessive flow through the mitral valve and an enlarged orifice, there could be presence of mitral insufficiency. Now, if the patient is having mitral insufficiency, in the initial palliative stage, there might not be any problem. But when we are thinking about staged procedure, if we go further, like BD Glenn or Fontan surgery, in those situations, if there is mitral insufficiency, we have to address that regurgitation, we have to correct it surgically. What about the left ventricle? The morphologic left ventricle is enlarged and hypertrophied. The muscle fibers of the left ventricle are abnormally aligned and irregular. Similarly, the collagen content of the tricuspid of the left ventricle of the tricuspid atresia anatomy is increased. Now, this type of remodeled architecture and increased collagen matrix may contribute to abnormal contractility or diastolic function, or both. That is, both systolic and diastolic dysfunction. Why it is important? Because post-Fontan repair, there is development of low cardiac output, and the background of failed ventricle is because of this remodeled left ventricle in the preoperative period. So this is the reason why we'll find post-Fontan repair LV dysfunction or low cardiac output. What about the right ventricle? The right ventricle is almost always hypoplastic in tricuspid atresia. In general, the size of the RV cavity is determined by the anatomic type of tricuspid atresia and correlates with the size of the VSD. If the VSD is very large, you can find not hypoplastic or rudimentary RV, but an area above those. The cavity usually contains an infundibulum. The sinus portion is absent. I mean, sinus portion of the RV is absent or rudimentary, with remaining part of the trabeculae, and communicate with the LV via the VSD. The RV inlet is absent in all cases. So, whenever there is presence of a RV cavity, the cavity is almost always formed by the infundibulum. Now, coming to the pathophysiology. Tricuspid atresia is an example of single ventricle physiology. By definition, in types 1 and type 2, no communication exists between the RA and the RV. So, systemic and coronary venous return go to the right atrium across the foramen ovale or the ASD into the left atrium, where it mixes freely with the pulmonary venous blood. So, right atrium is accommodating blood coming to the systemic veins, that is the SVC and IVC and the coronary sinus. From there, through the ASD or through the foramen ovale, it is going towards the left ventricle. where already left atrium, where the left atrium is already having its own blood from the pulmonary veins. So it is the left atrium where mixing is happening, both the blood from the right atrium and from the pulmonary vein. Now this all venous return flows into the left ventricle, from where it may pass in several ways, depending on the ventricular anatomy, the position of the great arteries, and the presence or absence of pulmonary or systemic arterial obstruction. So there could be presence of DTGA or LTGA. There could be presence of restrictive or non-restrictive VSD. There could be presence of aortopulmonary collaterals. There could be presence of PDA. So based on this anatomical variation, the LV output will be circulated. In type 1, that is normally related great arteries, patients with a VSD, left to right ventricular shunt occurs, thus perfusing the lungs. There is no problem in lung perfusion. But in absence of the VSD, the pulmonary circulation is derived either via PDA or through bronchopulmonary or aortopulmonary collateral vessels. In type 2, that is DTGA, the patients type 2 patients, the pulmonary blood flow is directly derived from the left ventricle as it is DTGA. But the systemic blood flow is now getting blood via the VSD and the right ventricle. The magnitude of pulmonary blood flow is the major determinant of clinical features in tricuspid atresia. As you know, there could be pulmonary atresia, there could be pulmonary stenosis, or no pulmonary, no interruption of pulmonary blood flow. According to these three types of pulmonary blood flow, there will be development of clinical features. How? See, an infant with markedly decreased pulmonary blood flow because of pulmonary atresia will present earlier in the neonatal period with severe cyanosis, hypoxemia, and acidosis. An infant with markedly increased pulmonary blood flow because of absence of any pulmonary stenosis or atresia does not have significant cyanosis, but usually presents with signs of heart failure because of pulmonary over-circulation. Although there is some overlap, patients with decreased pulmonary flow usually belong to type 1, and those with increased pulmonary blood flow are usually type 2, and occasionally type 1C. So what is type 2? Type 2 is DTGA with tricuspid atresia and presence of VSD in all three subtypes. And what is type 1C? That is the normal great artery without pulmonary stenosis and presence of non-destructive VSD. When the VSD is large and non-destructive and the pulmonary valve is not stenotic, the pulmonary blood flow is proportional to the PVR and SVR ratio. If the PVR is more, there will be less pulmonary blood flow. If the PVR is less, there will be more pulmonary blood flow. Why this information is important? Because based on this principle, we have to manage the patients while we are providing anesthesia. While we are providing anesthesia, we have to keep the PVR-SVR ratio almost similar to 1:1 ratio. Now, sometimes there is episodes of acute hemodynamic changes. In the neonatal period, closure of the PDA in tricuspid atresia patients with pulmonary atresia happens. And whenever there is sudden closure of the PDA, as you know, with pulmonary atresia, the child is surviving. I mean, the pulmonary blood flow is prominent or present because of this presence of PDA. Now, if suddenly PDA closes, there will be severe hypoxemia with acidosis and grossly reduced pulmonary blood flow. Now, interatrial obstruction leads to systemic venous congestion and may necessitate atrial septostomy. So, as I mentioned, that there will be definitely presence of either ASD or presence of any foramen ovale. But if because of this aneurysmal dilatation and aneurysm formation of the PFO or the right atrium, the PFO can be closed. So if the PFO is closed or the ASD is restrictive type, means the gradient across the RA and RP is more than 5 millimeter of mercury. So in these situations, definitely the blood flow from the RA to the LA will be reduced. Again, there will be hypoxia. There will be reduced systemic blood flow because now the LV is getting lesser blood, and at the same time there will be systemic venous congestion because now RA has to there will be accumulation of excessive blood within the RA. Now, progressive diminution and spontaneous closure of the VSD sometimes may occur. This leads to decreased pulmonary blood flow when the QPQS ratio is less than 1 in patients with normally related grade vessels, that is type 1, or where there is subaortic stenosis, that is in LTGA type 3B, and decreased systemic blood flow, that is QPQS ratio more than 1 in patients with DTGA, that is the type 2 variety. What about the investigations? Again, based on these two subsets, that is pulmonary atresia with reduced pulmonary blood flow and no pulmonary stenosis with non-destructive VSD, the chest X-ray feature completely varies. In patients with diminished pulmonary blood flow, the heart size is either normal or minimally enlarged, whereas in those with increased pulmonary blood flow, the heart size is moderately or severely enlarged. ECG is very interesting. There could be right atrial hypertrophy, an abnormal superiorly oriented major QRS vector, the so-called left axis deviation, and left ventricular hypertrophy. So whenever we are getting LVH with left axis deviation and right atrial hypertrophy in a cyanotic baby, think about tricuspid atresia. Echocardiogram is fair enough to diagnose after birth. The hallmark of the tricuspid atresia is the atresia of the tricuspid valve with a dense echogenic band in the location which is normally occupied by the tricuspid valve. There could be presence of enlarged right atrium, left atrium, and left ventricle, along with hyperplastic right ventricle. So you could see in this picture that this is the region where normally tricuspid valve is present, but you could see in echo there is presence of a dense shadow. You can consider as a band, and this classical anatomical variety signifies the presence of tricuspid atresia. There is no flow from the right atrium to the right ventricle. So in some situation, the echocardiogram is not adequate enough to diagnose. So in this situation, we might require the cardiac cath. But apart from that, the cardiac cath is also required to obtain precise hemodynamic information such as mean PA pressure, pulmonary arterial resistance, that is PVR, and LVDP. Particularly, these are important before any Glenn procedure or Fontan surgery. Sometimes it is required to determine the PA size, its distribution pattern, and to identify distortion or arteriovenous fistula from previous palliative procedure. It is also required to assess ventricular function and atrioventricular valve competence. Location and size of single or bilateral SBC is important because before Glenn procedure, you have to know whether there is bilateral SBC is present or not, because accordingly surgical plan will be changed. So cardiac cath is mainly required before the Glenn procedure, but sometimes when echo is not enough to diagnose, cardiac cath can be used. Now coming to the management. About the management part, I have restricted today's discussion about initial optimization followed by either PA bending or the modified petition, depending upon the classification, the anatomic variety. The rest of the part about the management, that is BD Glenn and the Fontan procedure, I will discuss in another class when I will discuss the single ventricle lesion. So what about the management part or the preoperative optimization? Prostaglandin E1 infusion is required sometimes to maintain the patency of PDA for ductal dependent pulmonary or systemic blood flow, because some patients, in some patients, the pulmonary blood flow is dependent upon ductus arteriosus, and in some patients, the systemic blood flow is dependent upon PDA. So in both these two types of patients with the Tricuspid Atresia, when it is ductal dependent circulation, the PDA to be maintained by the prostaglandin infusion in a dose of 0.05 to 0.1 microgram per kg per minute. Now, apart from that, we have to maintain the neutral thermal environment, the normal acid-base status, the normoglycemia and normocalcemia, because any situation which is going to close the PD after birth is actually placing the patient in further complication. So, in continuation of that, no more than 40% FiO2 is to be used unless patient is having any pulmonary parenchymal disease. Otherwise, your PDA will be closed. If the patient presents with congestive heart failure like type 1C or any types of type 2, then anticongestive therapy is required for preoperative optimization. Now coming to different types of palliative procedure. Palliative procedures are done before the definitive procedure because we have to go for the single ventricular physiology in long run, that is BD Glenn followed by the Fontan procedure. Prior to this BD Glenn and Fontan procedure, we have to perform some palliative procedure in the neonatal PDA. Now, palliative procedure is can be performed in two ways. I mean, two types of patients. If the patient presents with decreased pulmonary blood flow, the options of palliations are: number one, aorta to pulmonary artery direct palliation with a Gore-Tex shunt, ports anastomosis, that is the creation of shunt between the descending aorta to LPA, Watterson-Cooley shunt between the ascending aorta and the RPA. But these three types of shunt, they are not performed nowadays because we are having modified BT shunt in our hand, which is placing a shunt between subclavian artery and the ipsilateral pulmonary artery. This is the picture. You can see these are the locations of where this is the location of performance of port shunts. This is location of performance of Watterson-Cooley shunt. This is the modified BT shunt between the right subclavian artery and the right pulmonary artery. That shunt can be placed in the inguinal artery also. This whether to place in the subclavian artery or the inguinal artery, the decision is up to the surgeon. But if the patient presents with increased pulmonary blood flow, then if optimal anticongestive therapy does not produce the adequate relief of symptoms, PA bending should be considered in type 1 patients, particularly in type 1C. In type 2 patients, PA bending should be performed once the patient is stabilized with anticongestive therapy. So these are two extreme categories, that is decreased pulmonary blood flow, go for modified BT shunt, increased pulmonary blood flow, go for PA bending. So a brief discussion about the modified BT shunt. The modified BT shunt entails anastomosis between the subclavian artery and the mainly right pulmonary artery with a placement of tube graft, that is the Gore-Tex graft. Commonly, it is placed on the right side. Traditionally, it was performed via thoracotomy, but nowadays it is mostly done via median sternotomy. And generally, it is performed not under CTVS bypass until and unless the child is very sick. The ultimate goal of anesthesia is to augment the pulmonary blood flow, that is balanced with the systemic blood flow with a saturation, targeted saturation, goal of saturation is 75 to 80%. It has been seen that with a saturation of 75 to 80%, we can achieve a QPK ratio of 1. In a thoracotomy approach, there will be impairment of oxygenation and ventilation due to the lung retraction. Surgeon places the large mop to reduce the lung volume for the better exposure. And if because of that there is severe lung collapse and you are struggling with the saturation, then with intermittent lung reinflation, that situation can be overcome. And once the procedure is over, definitely by manual bagging, both the lungs should be reinflated adequately before shifting the patient to the ICU. Now, what about the placement of arterial line? The arterial line is not typically placed in the same arm as the side of the modified BT shunt. That is, if we are performing the modified BT shunt on the right side, the radial artery line to be done on the left side, and the vice versa. The heparin dose, if the procedure is performed without CTVS bypass, the dose is a vascular dose, that is 100 units per kg before clamping for the shunt placement. And if at all it is to be performed under CTVS bypass in a very sick patient, the dose is as usual 300 to 400 units per kg. Now, a big controversy about the heparin reversal. It is based on the surgeon's choice. The decision to be taken according to the institution protocol, the preference of the surgeon and the anesthesiologist. So it is not true that in all cases heparin should be given. Protamine should be given to reverse the effect of heparin. Sometimes surgeon even said that no protamine to be given because there is chances of shunt blockage in the postoperative period. Sometimes we give partial dose of protamine. So again, I'm telling that it is entirely on the decision to be taken jointly between the surgeon and the anesthetist. Platelet transfusion, it is better to avoid, but if at all to be used, with caution to be used, because again there is chances of risk of shunt thrombosis. In some institution they use FFP because in some institution they try to keep the hematocrit at a basic lower level to reduce the hematocrit. Sometimes they do aspirate the blood, and the amount of blood, whole blood they are aspirating, they replace it with FFP. Again, it is controversial. This practice depends upon the institution protocol. What are the advantages of modified BT shunt? It preserves the blood flow to the arm. So the blood flow to the arm is not jeopardized if a Gore-Tex graft is placed in the form of modified BT shunt. It avoids excessive pulmonary blood flow when appropriately sized. So pulmonary overcirculation in the post-procedure period is not found. There is less chance of thrombosis if again adequate size of the shunt is chosen. Now, post-procedure desired SpO2 is 75 to 80%. Do not go for do not keep your goal of SpO2 more than 80%. Sometimes you could find that your desired SpO2 is not achieved. Low level of SpO2, what are the differential diagnoses? Number one, hypotension. Hypotension can cause low SpO2 because of low output. Now, shunt narrowing or shunt occlusion, which is quite common in the post-operative period. Inadequate shunt size. That shunt size is not corroborating with the child's body weight, and the pre-existing lung parenchymal disease. Now, following modified BT shunt, some changes occur which will guide you that no, the shunt is functioning well and the patient is improving. So there will be sudden, after the clamp is over, after the procedure is over and the clamp is removed, there will be rise of EtCO2 because cardiac output is improved. There will be fall of diastolic blood flow because of diastolic runoff through that BT shunt, and there will be rise of saturation. Now, what about the size of the shunt? As I'm talking about, repeatedly talking about the importance of size of the shunt. Generally, in a term neonate having a body weight of 3 kg, the ideal shunt size is 3.5 millimeter. There is risk of sudden thrombosis and acute occlusion when smaller size shunt is used, that is 3. This occlusion causes severe hypoxemia after improvement of saturation, and it is confirmed by absence of shunt murmur and absence of shunt flow on Doppler cover flow imaging. Now, if the shunt size is too large, that is 4 or more than 4, there will be pulmonary overcirculation. So, and that pulmonary overcirculation is manifested by pulmonary edema on chest X-ray, unnecessary improvement in saturation, that is SpO2 more than 85%, and very important is that difficulty to wean from mechanical ventilation. In the post-operative period, immediate post-operative period, heparin to be started in a dose of 10 to 12 international units per kg body weight, and also aspirin to be started when the child started oral feeding. Now, coming to the PA banding. PA banding is performed in a child of Tricuspid Atresia having increased pulmonary blood flow. Now, while I am discussing the PA banding, I will discuss PA banding as a whole, not the aspects of PA banding related to the Tricuspid Atresia only. So, what are the indications of PA banding? PA banding is generally indicated in 2 types of lesion. If there is excessive pulmonary blood flow to reduce pulmonary overcirculation, and in some situations where you need to have LV conditioning, LV training. So what are the indications? Number 1, muscular Swiss cheese VSD. As I will mention in my class of VSD, that muscular Swiss cheese VSD cannot be closed surgically. So it is the treatment for muscular Swiss cheese VSD is PA banding. Now, multiple or single VSD with confounding surgical comorbidities are present, like very low birth weight, sepsis, pneumonia, intracranial hemorrhage, multi-organ failure. We cannot go on CV bypass and we cannot perform extensive procedure of VSD closure. The initial palliation can be done by PA banding. Number 3 is that unbalanced atrial defect with borderline left ventricular hypoplasia as a palliation prior to committing a biventricular repair. So, you know that this is a potential candidate for biventricular repair, but for the certain period, you have to wait for the development and growth of the child, and this type of borderline left ventricular hypoplasia, the palliation can be done with PA banding. Next indication is that high-risk infant with HLHs, where bilateral PA bending and PDA stenting is performed for a short-term surgical palliation. The another indications are number one, about the LV. What about the LV training? Preparation of left ventricle in patients with DTG who are presenting lately, that is more than 1 month, for a subsequent staged arterial switch operation. Detailed about this procedure I will discuss when I will discuss about the DTG and the arterial switch operation. Now, preparation of the LV in a patient with LDGA for a subsequent staged double switch procedure. Reduction of TR in patients with LDGA without VSD, and as an adjunct procedure in patients with single ventricle anatomy and who is having antegrade pulmonary blood flow at the time of PD claim, to maintain some sort of antegrade flow but maintain the low superior vena cava pressure. So the PA bending, while we are doing the PA bending, a band is placed within the main pulmonary artery before the branching happens. Now, how much to reduce the circumference of the main PA with this band is determined. That the size of the band is determined by a formula known as Trussler formula. Now, Trussler formula is depend upon 3 broad categories. That is, number one, non-cyanotic mixing lesion, that is VSD. The formula is 20 mm plus 1 mm per kg. That is, if the child is having 3 kg body weight, the size of the band will be 20 plus 3, that is 23. If it is a mixing lesion, that is DTGA with VSD, the formula is 24 mm plus 1 mm per kg body weight. And the third category is single ventricular heart physiology with a plan for future palliative Fontan surgery, that is Tricuspid Atresia. The formula is 22 mm plus 1 mm per kg body weight. So these are 3 formulas for 3 different types of lesions posted for PA bending. Now, final band circumference is determined by the pressure gradient through the band, distal PA pressure, and potentially by the degree of desaturation if the patient has single ventricle physiology. It is important if you require to place a central venous catheter not to use the IJV, because you use the femoral vein. Why? Because when you are placing the PA bending, definitely in future you will go for the single ventricular physiology. There is planned procedure for BD Glenn or Fontan surgery. There you will require the usage of that IJV intact, because if there is presence of any clot or thrombus within the IJV for the previous placement of any central venous catheter, that will not ideal for a BD Glenn or a Fontan surgery. An important anesthetic principle for the PA bending procedure is that the anesthetist must achieve a baseline state that is neither too deep or too light at the time of PA bending, so that the tightness of the band is appropriate for the patient. What does it mean? It means that PA bending, when we are doing, we must create a scenario as much as possible as normal. Means when the patient will be extubated, the same amount of pulmonary blood flow will remain as like the pulmonary blood flow under anesthesia. So you know that depending upon the type of anesthesia, the loading condition changes. And when the child is extubated not under anesthesia, the loading condition changes. So because of that loading condition, definitely the hemodynamics will be changed. So keeping the hemodynamics or the loading condition as much as possible similar between the procedure and after the procedure. So based on this principle, the tightening of the PA bending is performed. The PA band is adjusted temporarily with surgical clips, and then blood gas measurement is performed after a steady state condition, as I already mentioned, are achieved, and the band then is permanently secured with non-absorbable sutures. Now, what are the hemodynamics we must consider adequate after the PA band procedure? The PA pressure distal to the PA band should be around 30 to 50% of systemic pressure. The oxygen saturation is approximately 75 to 85%, keeping the FiO2 less than equal to 30%. Increase in systemic blood pressure by 5 to 10 millimeter of mercury. If you are doing an ABG, the desired PO2 level is 40 to 45 millimeter of mercury, and peak velocity across the PA band is 3 meters per second. Now, if the band is too tight, there will be profound cyanosis and bradycardia. That is, the child is not tolerating the that level of tightness of the PA band. And on the other hand, if the band is too light or too loose, then there will be no change from the baseline condition. If there is associated significant coarctation of aorta is present, it should be addressed when the PA bending is performed. Now, coming to a special type of operation which is performed in tricuspid atresia, that is Damas-Kay stem cell operation, that is DKS. It is rarely performed. The DKS operation is performed for tricuspid atresia where there is significant subaortic or aortic obstruction is present, or with a or when there is a presence of restrictive VSD. In DKS operation, main PA is anastomosed with the aorta, which is eliminating actually the need for PA bending. The procedure is like that. NPA is separated just below its division into RPA and LPA, its main branches. The end of the MPA is then joined to the side of the ascending aorta directly, allowing blood flow from the LV to the aorta directly, because there is aortic or subaortic obstruction. So now from the LV to the PA to the aorta, the blood flow is continuing. When VSD is inadequate, the DKS procedure is combined with a BT shunt, and the DKS procedure is combined with BD gland in older infants with established subaortic obstructions. Now, this is the picture of DKS operation. You can see that this is the main PA, which is actually communicating to the LPA and the RPA. Now, the main pulmonary artery is ligated and transected from its branches, and it is anastomosed with the aorta directly. So there is anastomosis from the pulmonary artery to the aorta directly, and the portion of the MPA where it is joining to the branches is sealed with a patch, and you can see that a BT shunt has been placed between the right subclavian artery and the right pulmonary artery. So this is about the DKS. So that's all about the tricuspid atresia management. Thank you all. If any question is there, I'd like to answer. Is there any question?
Thank you, sir.
Dr. Anmol,
No question, sir. Just thank you, sir. Really appreciate.
so have you
Concept.
understood the tricuspid atresia anatomy and the pathophysiology, the management options?
Yes, sir. Better than before, sir. Much more clarity, sir. Now.
Go and read. Now you will understand, because in my DRNB days, it was difficult for me also to understand about the particularly the anatomy of the tricuspid atresia and the pathophysiology. So now go and read. I think the confusions will get cleared.
Thank you, sir.
Any more questions? I think all have understood the tricuspid atresia very well, so that's why they are not having any question. Anyway, if you are having any question, you can ask me in. Okay, so Preeti has a question. Sir, what all should be monitored post BD glen, especially coagulation? Dr. Preeti, I will discuss BD glen and Fontan in a different class thoroughly, because single ventricle physiology, single ventricle lesion, and their definitive procedure, that is BD glen and Fontan operation, needs a long time to discuss. It will not be justified enough to discuss the PA man, the BT shunt, and BD Glen and Fontan in the same class. So don't worry, I will discuss in detail about the BD Glen and Fontan in a different class. Okay.